Okay, if we then move through to sort of like our patellofemoral soft tissue, we have the retinacular structures. And again, they're probably not well covered at undergraduate, but we have a whole host of structures which go from the patella to either the ITB or the meniscus or the tibia. And these again are fairly highly innervated, so they're going to be very sensitive to being stressed and stretched or having direct trauma, because again, these people could get hit on the leg with a ball, with a foot, from a kick or a stick, and so we could get local tenderness with these structures. Now, what we have is we also get one of those crazy neural reactions here with this tissue, with an absolutely excessive increase in substance P and a hypersensitivity to these tissues if they get injured. So what we're also looking for here as a differential is a tissue which doesn't appear to have had a lot of trauma, but is almost massively hypersensitive to palpation. And this neovascularization especially seems to occur in the deep lateral retinacular, which goes from the lateral side of the patella to the ITB. So again, in those individuals who you perceive have tight ITBs causing their pain, it is probably because of the excessive loading of this deep lateral retinaculum. And again, in our adolescence, where we perhaps have had a growth spurt and we get those, in inverted commas, unstable patellas, which don't truly dislocate, but we feel as though might be on the verge of a subluxation event. Again, probably what we are seeing here is the stressing of the medial patellofemoral ligament. And this is a fairly consistent thing you see in that adolescent population, where they have a lot of tenderness on that medial patellofemoral ligament. So the medial patellofemoral injury is seen on MRI in a large number of ACL patients. And again, we get these medial pains in our ACL patients. And if we think about the mechanism of ACL injury, that's highly likely to involve a valgus stress. But that valgus stress will also create a lateral displacement of our patella, so stressing our medial patellofemoral ligament. So again, it's highly unlikely our ACL is a driver for pain in the knee. But in these early post-operative stages, we could have fat pad irritation through the surgery itself, but also medial patellofemoral damage through the mechanism. So again, an awareness of these soft tissues is important with some of our other big knee conditions. And we're going to figure out what's going on here, unfortunately, not by any clever diagnostics. It's probably a diagnosis of exclusion and then being able to palpate the appropriate structures. And what we've got is a little video which shows palpation around the knee, but the key things we are looking for are these retinacular structures, but also being able to differentiate them from things like the plica and the infrapatellar saphenous nerve, for instance. When we're looking at the retinacular structures, we've got to be really clear that's what we're palpating, as opposed to palpating some other anatomical structure on the knee. So if we work our way around the key features of the inside of the knee, if we're looking for our medial patellofemoral ligament, again, if we palpate the medial border of the patella and we come under, what we will come to is a thickening which is stopping us palpating the edge of the patella, and it's usually in the superior half of the medial border, which is about here, and this will track down to the medial epicondyle. So that would be our medial patellofemoral ligament. Our other retinacular structure we're really interested in on the medial side of the knee is our medial patellar tibial ligament. So again, if we feel underneath the patella, we will come to, again, a rise of tissue, and then usually there's a gap and we hit the patellar tendon. So again, this here, and again, we can track it out to our tibia. So we have our two main retinacular slips, our medial patellofemoral ligament and our medial patellar tibial ligament. And then a couple of other things of interest on this medial side can be the plica. So again, the plica tends to run in this direction. So if we feel outwards medially, what we feel for is usually what could be described as a flat, small hose pipe.
and it usually sits 1 centimetre-ish beyond the patella, and it runs in this sort of direction. And then finally on the medial side is our infrapatellar nerve. This comes out between the vastus medialis and the adductors, generally turns the corner to go towards the knee at around the epicondyle. And then what we're feeling for is a string-like structure, a cord which we almost flick across to find. And sometimes the patient will find that mechanically sensitive and give you that little knowing look that you're on a nerve. So we have something which tracks almost as a J. And usually there's a couple of branches, and there's a branch which also will sit over the tibial condyle as well. So this would be the typical places where we'd find our infrapatellar our plica, and obviously we've got our retinaculum. On the lateral side, our first retinacular slip we really need to identify is our ITB, and our ITB comes down the lateral aspect and tracks around in front of our head of fibula and comes into the side of the tibial tubercle. So again, what we feel it is a pretty thick, dense band on the lateral thigh, and then it becomes narrow as it comes around. So this generally gives us a J, which comes around in front of the head of the fibula and into the side of the tibial tubercle. Off our ITB is our deep lateral retinaculum of our patella. And again, the easiest way to feel this is to expose the lateral border by tilting. And again, what you will see is it's quite a thick band, which can run for anything up to the third of the length of the patella. So here, the thickness is actually about that thick off a relatively small patella. And this is going to track down to our ITB. So again, quite a thick, dense structure. And then finally, what we have on this side, which can be a pain driver, is the bottom of our vastus lateralis, or the vastus lateralis aponeurosis, which again comes into usually the top of the patella or the quadriceps tendon and goes out to the ITB. So again, we have a structure which comes in this sort of direction, which again can be another pain driver on the lateral side of our knee.
If we're looking at managing these soft tissues, the management which works virtually 100% of the time is to tape and offload. And we can tape and we can offload those structures. Generally, if it's a medial structure, we're going to glide the patella or tilt the patella medially. And again, we've got a little video showing some of those techniques. But patella taping is incredibly important. Because we've had pain in the knee, we're probably going to need to get our quads going because we're likely to have had inhibition. And if we think here we've got a valgus knee position or an internal femoral rotation or a hip adduction, we're going to need to try and optimize those movements to stop that lateral glide of the patella stressing these structures.
We're just slightly covering the patella with the tape. And then what we get is we get this beautiful wrinkled knee, which shows what we're probably doing is just lifting the fat pad and some of the superficial tissues, which is possibly just taking a little bit of load off them. Now, if we want to add a little bit of loosely positional control to that, we might split the tape as this has been, and then we'll apply to try and gain some proprioception or a little bit of mechanical directional control. So one of the top tips is always put your split about 1 centimetre from the patella, so you don't embarrass yourself when you stretch it and end up covering the patella. And what we're doing is, again, we're just removing the backing tape, and again we're just putting that pre-stretch on the tape so that when the stretch recoils, we're just pulling that patella slightly superiorly. Oh, and we might want a little bit of a medial glide as well. So again, what we can do is use another split tape to just try and get us some degree of medial glide. So again, same thing, remember to have the split away from the patella a little bit, which then gives you room to maneuver to bring the arms around and get some of that recoil back to the medial side.